form a large bulk of our patient, but sometimes we do get confused whether to treat these patients or not, and even with non-attentional glaucoma, because the guidelines are not very clear, or maybe we are not very accustomed with the guidelines whatever is available. So ocular hypertension treatment study is definitely the most elaborate study on ocular hypertensive patients, and very quickly going through what their guidelines is. Basically what they have tried to understand that how many patients of ocular hypertension will develop primary open glaucoma if you treat, and if you don't treat. So basically what benefit we are trying to give our patient when we treat our patients. So they divided patients into two groups. One group where they treated and the aim was to basically reduce the IP by 20%, and the second group which they just observed. And what they found that if you treat, the overall risk of progression from ocular hypertension to primary open glaucoma is around 4.4% over a 5-year period. But if you don't treat, 9.5% patient of ocular hypertension will develop primary open glaucoma. So interestingly, if you don't treat your ocular hypertensive patients also, and they had pressures up to as high as 32 millimeter mercury, 90% patient will not develop primary open glaucoma. And if you treat, you are definitely reducing the risk, but the risk reduction compared to the amount of treatment you have to give, it's what we call as the number needed to treat, is as high as 20. So if you're treating 20 ocular hypertensive patients, you are just preventing one patient to develop primary open glaucoma, and that also the patient will develop into early glaucoma. It's not like he's going to become blind. So we have to understand that we definitely treating all ocular hypertensive patients are not required. So now how to decide which patients to treat and which patient not to treat. So if you go for the subgroup analysis of these patients, they have shown very clearly those patients where the central corneal thickness was more than 590 with a pressure of less than 24, the risk was only 2%, which is very, very low risk. These patients can be very easily observed. But this is the group which actually needs to be treated. Those patients where the pressure was 26 and above, with a central corneal thickness of less than 555. If you see the Indian population, majority of our patients actually have a CCT less than 555. So if you have a patient where the pressure is 26 and more, especially the corrected pressure, these are the patients where actually you should be considering treatment. The rest of the patient, you can very well observe the patient after having a proper baseline documentation. Other few risk factors which they noted in their study. So if you have a patient where the high baseline IOP is there, thinner CCT, large vertical cup disc ratio, high PSD, and disc hemorrhage, these are the patients, if you see at the time of presentation, these patients also you can consider as an option for treatment. Interestingly, in their study, family history of glaucoma was not a risk factor which we routinely consider in our patients. Same thing has been shared by American Academy of Ophthalmology in their guidelines also. But if you're following up this patient, make sure you have a proper documentation of the disc, take a disc photograph, preferably do a perimetry also, have a baseline IOP, check the IOP 3-4 times. If you can do a diurnal or at least an office diurnal, have a diurnal, do a CCT, so that when you're following up this patient maybe every 4 to 6 monthly, you know what baseline data you have to compare. And then when you see changes in the disc, when you see changes in the field, you can treat this patient accordingly. There's a glaucoma 5-year risk calculator are also available based on this OHT study, where they use age, IOP, CCT, vertical cup disc ratio, and pattern standard deviation as a criteria to decide what is the risk of patient developing glaucoma over a 5-year period. So based on this data, you can tell your patient, okay, you have this risk, and then you can discuss with the patient whether they want to be treated or not. But whatever, they have a proper documentation, and do clearly mention that they need to be under follow-up, because there have been so many cases where we have left the patient came for follow-up after 6 months, then they were lost to follow-up, and then they came after 4 to 5 years, they had proper glaucoma. So very important, mention very clearly in your file that they have to be under follow-up. Whether they follow up or not, it's a different issue, but they has to be properly documented. So like all ocular angles, all ocular hypertension don't need to be treated, also because the prevalence of ocular hypertension is much more than primary open glaucoma in our population. So it's almost 7 to 8 times more than primary open glaucoma. So if you start treating them, you'll be unlessly treating a lot and lots of patients. Coming to non-attentional glaucoma, the biggest problem in non-attentional glaucoma is, by definition, you should have an intraocular pressure when you've done a 24-hour diurnal within the range of less than 21 millimeter mercury, but most of us don't have the facility to do a 24-hour diurnal evaluation. So a lot of our so-called non-attentional glaucoma may actually not be a non-attentional glaucoma when you actually have a 24-hour IOP. Plus, an ideal normal hypertension glaucoma should have a progressive field damage, which again sometimes is difficult to explain and difficult to demonstrate because a lot of time it's a one-time damage. So a lot of people believe that primary open-angle normal hypertension glaucoma actually is a continuum of primary open-angle glaucoma, and where IOP is not only the risk factor, there are other risk factors also. Coming to prevalence, there are not too many data from India where they have shown the prevalence, but we all know in Japanese population they have shown as high as almost 90% of their patients do have a normal tension glaucoma. But the role of IOP is still there, and collaborative normal tension glaucoma study has shown that if you treat this patient, you can reduce the risk from 35 to 12%. So definitely if the normal tension glaucoma patient also, even if the pressure is normal, bringing them down further definitely helps your patients. But interestingly, in their study, 50% of normal tension glaucoma didn't progress. So take home message is, if you have a patient with normal tension glaucoma, you're not very sure about the diagnosis, maybe the disc is like borderline, the perimeter not clearly matching, all the pressures are normal, you can do a baseline evaluation, do a field, take a disc photograph, do a CCT, and you can very well observe the patient, do a field every 6 months and see whether the patient are actually progressing or not, because as they have shown, 50% of patients may not progress over the time period. We also need to look into other factors when we're treating normal tension glaucoma, like the vascular factors, the neuroprotection, and we all know there are a lot of studies coming about the CSF pressure. Also, vascular factors are definitely more associated with normal tension glaucoma. We see more disc hemorrhages in these patients. In fact, if you see a disc hemorrhage, you should always think whether you are dealing with a normal tension glaucoma or not. Also, to have a history of migraine, whether there is a history of sleep apnea, look for nocturnal hypertension. Nocturnal hypertension, for a cardiac point of view, is good for the heart, but if you have a dip of blood pressure more than 20%, definitely it's bad for the eyes. You can take a help of your cardiologist, have a 24-hour BP assessment, and at least you can modify their blood pressure treatment. Ask them to not to use blood pressure medicines at night. Also, you can discuss with the cardiologist if we can reduce the blood pressure medications to have more better control of the blood pressure. Over control of blood pressure is not good for a glaucoma patients. Dr. Harry has also highlighted that in classical normal tension glaucoma, you should consider not using beta blocker. But again, this is controversial. There are some studies which have shown that beta blocker do not affect much in normal tension glaucoma. But if I have a patient of a normal tension glaucoma who is progressing even on prostaglandin, and if an option of using a beta blocker or maybe a carbonic anhydrase inhibitor, I should be preferring a carbonic anhydrase inhibitor in these cases compared to a beta blocker. Lodgers has highlighted the role of brimonidine as a neuroprotector, and they have shown that patients of normal tension glaucoma, when you treat with brimonidine versus timolol, although the pressure control is same, the risk of progression was more in the patient with the beta blocker, and they postulated that probably it's a neuroprotective effect of brimonidine which helps you in these patients. So basically, again, similarly, if I have a patient progressing, so in normal tension glaucoma, your drug of choice will always be a prostaglandin, but next to prostaglandin, you can consider something like a brimonidine for its suspected neuroprotection, or a carbonic anhydrase inhibitor for its suspected vascular factor protection as a better option. Coming to the last topic, the CSF pressure in glaucoma. If you see, this is the lamina cribrosa, and lamina cribrosa is affected by two pressures on the two sides. In the front, you have the intraocular pressure, which is basically trying to push this backward, and from behind, the CSF pressure sort of gives you a support to the lamina cribrosa. So what happens in that, what this is called as the translamina cribrosa pressure. Generally, the IOP is higher than the CSF pressure, and this is the reason why we get this type of cupping. But when the CSF pressure is high and the IOP is low, you get papilledema. So basically, when the CSF pressure is high, it is pushing the disc forward and you get papilledema. On the other hand, when the CSF pressure is low and the pressure is high, you get these type of cupping. So there is a postulate that in cases of normal tension glaucoma, your CSF pressure is low, and that is why the disc itself is susceptible to pressure ranges. So even with the normal pressure, you develop cupping. Similarly, ocular hypertensive patient has been shown to have a higher CSF pressure. That is why they can withstand 25, 30, 35 pressure. So this CSF pressure do have a role. And last point, lifestyle modification. You have to have a regular exercise, stop smoking, because these normal tension glaucoma patient, overall systemic factors do come into play. So to conclude, as I was telling you, prostaglandin will be drug of choice, but I'll probably preferring a brimonidine and carbonic anhydrase inhibitor as a second line, and trabeculectomy also are useful to bring down the pressure. Also, whenever there is atypical progression, do consider neuroimaging and have an overall evaluation of the patient, especially with a cardiologist, to have make sure you're not missing any other causes of ischemia. Thank you so much.
Thank you so much. Any questions for Dr. Maneesh Singh? Okay, Maneesh, I have a question regarding OHT. Like you mentioned a number of drug of choices for NTG patients. So for OHT, do you start have something specific in mind when you start?
See, in all our patients, whether it's ocular hypertension or a primary open glaucoma or even a non-intentional glaucoma, we consider using prostaglandin as the best drug because we all know has the least side effect profile with the best IP control. In case the prostaglandin is contraindicated or the patient is allergic to that particular drug, then only we don't use prostaglandin. But even in angle closure glaucoma also, once you have done the PI, angles have opened up, the inflammation is under control, we always use prostaglandin as the first line drug, except maybe probably the secondary glaucomas.
And one more question regarding NTG. Before you establish a patient as NTG, you should have a DVT, a diurnal variation. So in your busy clinical practice, I know that's not possible. So how do you deal with that? How do you label a patient as
That I
NTG?
was telling you, ki in reality, most of our NTG patients, we are not sure they're actually NTG or not. So that is a big problem we face in, not only in private practice, even in institute also I have worked previously. Doing a 24-hour diurnal, admitting a patient is practically very difficult. Most of us won't do it. You will be dependent on some of the technician. You don't know how sincerely they are doing it, what instrument they are using. Then waking up patient at 3 o'clock at night. So practically it's difficult to do a 24-hour diurnal. What we do often, we do an office diurnal starting say 8 o'clock in the morning till 6 o'clock, 7 o'clock. Again, it's not a replacement of 24-hour, but you can get an idea that instead of treating the patient on one pressure, you are getting say 6-7 pressure. So you have a better baseline data to understand what is the pressure and how much IOP reduction I need to go for these patients.
Thank you. Thank you so much, Maneesh. Yeah.
If it's negative, if we do not get high pressures, does not rule out anything. But if we get a high pressure during that time, at least it tells us that maybe it's a POAG or.
Azim, sir,
Yeah,
is there
and
anything you'd like to add?
so now I'd like to ask him, before we decide on an NTG patient, OHT patient and tell them, okay, you're off, we are not going to treat you after discussion. So what are the baseline parameters you convince yourself before, apart from the fields, your nerve fiber assessment, the central corneal thickness, your baseline IOPs, conioscopies, and then once you convince, and what is the point in which you decide to say that, okay, I'm going to see you only after, is it 6 months or 1 year? Are they going to come back with the routine fields and OCT routinely? Or do you just see them and clinically suspect and then do a fields or not? So what is your protocol to say that, okay, these patients are not going to come back to me often? What are the criteria and how often do you see them?
So for ocular hypertensive patients, initially what I try to do, whenever we see the pressures are more than 20, obviously we do a complete evaluation as you mentioned, have a proper CCT, have a gonioscopy. I always take a disc photograph because they have been very helpful. 10-year, 15-year back also patient we have taken a disc photograph, now we can see. And OCT I generally won't do for these patients, although ideally we should be doing it because the problem is repeating OCT in our setup, sometimes the cost becomes an issue. And we have also mentioned that the OCT technologies keep changing so fast that sometimes the discs don't change and the OCT machines have changed. So in my short practice of say 12, 13 years, 15 years of glaucoma, we moved from the status to the spectral domain, now the spectralist. So the machines have changed and the patient disc hasn't changed actually. So it's not very cost effective personally in my practice, but this photograph definitely. I'll do a baseline perimetry also, and I'll see what is the range of pressure. Maybe I'll do an office diurnal as I was mentioning. If it's a range of 20 to 25 with the CCT normal to higher, I'll just explain the patient that I don't even mention the term glaucoma. I'll just say that your pressures are high. You need to just recheck your pressure once in a while. Initially, I'll keep them under 3-month, 4-month follow-up, maybe for once or twice, and then sometime 1 yearly follow-up. Because after 2-3 follow-up, you can get an idea that the discs are stable, patient is not having any other problem. Do take a history of steroids also. Like also we take a history of homeopathic medicine. Sometimes these patients are taking or some skin ointment and all. That is also something important. And also, if they have some smoking and all addiction, I generally try to tell them ki you can stop smoking. So these things I try to do, and then based on that, mostly if the patients are stable, every yearly we follow up. But if the pressure is above 25, I generally won't be comfortable leaving a patient with a pressure of 26 and above, because again I was telling you I'm not doing a 24-hour diurnal. So if I'm leaving a patient with 25 above without doing a 20, I might be taking a risk. So these patients, I'll definitely tell them you'll be better off if you put on medication. Most patients I've seen, they prefer to be on medication. Some patient may say, okay, look, I stay close by, I can very well come every 3 to 4 months, so there's no issue. So these patients we can always ask to be in the close follow-up, and then accordingly we treat. So we always try to make the patient part of the treatment, and so that we can work in continuation.
Yeah, so that's what I wanted to stress. So in glaucoma, the most important thing is making the patient a part of treatment. And what we do in my center is we have a discussion with the patient and tell them put all the cards on the table and say that it's like wearing a seat belt. Your friends are driving without a seat belt, they didn't have an accident. Do you want to wear a seat belt or not? And then tell them these are the factors, these are the risks you've been having. What do you think? Do you want to start it or do you want to wait and watch? If the patient says, yes, I want to start, those are the patients I find usually come back to us regularly. If patients are reluctant to say, I'll come back later, then we keep a tag on them. And then we say, you still have to come back to us. And sometimes some patients slip the net. We tell them, even if you're transferring to another place, please make sure that you need to have your pressures checked. There can be students going overseas for studies. Just say once a year, please make sure you go. Don't go to an optical shop for glass checkup. If you go there, please make sure you see an eye doctor to get your pressure also checked.
Thank you so much. So we'll move on to the next topic. Now we know that dry eye itself is on the increase, and the incidence and prevalence of glaucoma is on the increase, and we've increasing number of drops to treat glaucoma. But we as glaucoma specialists are more concerned with the optic disc and treating the glaucoma part. So regarding dry eye, we are not that much concerned. So are we silent to this menace? To Dr. Sagar Barve is going to bring more clarity to this topic.
Good